last time I spoke, I presented some lumbar cases, and if you recall, lumbar has 3 basic approaches: anterior, lateral, and posterior. And then with posterior, we can do open, minimally invasive. With anterior approaches, we work with a vascular or general surgeon to do that. Lateral and posterior, the surgeon can do it. With cervical, there's really only 2. We go through the front and through the back. But there's some nuance to it, and I thought it would be worthwhile to talk about a few cases. And again, these are surgical cases. These are patients that are candidates for surgery, at least in my estimation. And I want you to be the surgeon, or think about how you would approach these cases as a surgeon. This patient had I think it was a motorcycle accident, and he comes in with weakness in his upper extremities more than his lower extremities, and you can see that he can barely move his hands. And then this is a few of the images that we did, or that the team did, after his accident. First of all, does anybody have any comments on what you see on the CT? Here on the left, there's some arrows to help if you want.
Only there's a radiologist here.
Yeah, and that's a good point. I actually think it's great to have Dr. Jackson here, and I also think that it's great for everyone in the room to sort of not only be the surgeon, but to be the radiologist when these images come up, because the more you look at and the more you sort of come up with your own conclusions and then look at the answer with Dr. Jackson's read, then you start to see the patterns, and it becomes a lot more, hello, come on in, a lot more recognizable. So anybody want to make a comment on what you see here?
Does Dr. Jackson put the arrows?
No, he doesn't. Well, sometimes.
Was the MRI ordered first, obviously, the CT?
CT was done first. Yeah, because this was a trauma patient, so they would do a CT scan right off the bat.
There's spinal compression.
Yeah, spinal cord compression. Seen maybe best on this image, clear off to the right. So if we're thinking about surgery here, one of the things is we need to make sure that we address the spinal cord compression.
Cord signal change.
Yep. Yeah.
T2 MRI.
It's subtle, but it's definitely there. The spinal cord demonstrates a little bit of increased signal change, which is consistent, right, with what we see on exam. He's central cord syndrome, upper extremity weakness primarily from a traumatic injury and bruise of the spinal cord. One other thing that I think is interesting, and we see this pattern over and over and over again, is the 2 levels where there's osteophytes on the CT are the same 2 levels where he has the spinal cord contusion. And it's probably for 2 reasons. One, there may be already some narrowing of that area. And 2, those areas that are stiffer are less compliant in an accident, so they're more prone to injury. And then on very careful view here, there's a tiny tear in the disc that you can see. So if you're going to do surgery for this, how would you approach it? What surgery would you, well, and also what surgery would you do?
Because it doesn't look like, it looks like most of the changes are in the front, not
Yes.
in the back.
Yep.
And it's a little bit easier approach, and it's a little bit possibly easier to recover as
Yeah.
well.
Yeah, I agree. I think that surgeries coming in through the front of the neck are much easier recovery. It's an easier approach for everyone. And a lot of cervical pathology is disc related, bone spur related, and we can access all of that from the front. Would anybody consider going in through the back? Which by the way, would not be wrong to do the back.
Could you do a lateral approach?
Not for the neck, no. There's vertebral artery and other structures that really prevent access to the cervical spine from a lateral approach, at least that I know of. Yeah?
Not an opinion, but a fun historical fact. Originally, all of them were done through the posterior
Yes.
approach, correct, historically, and then Ralph Cloward,
Yeah.
neurosurgeon, pioneered the ACD, the anterior approach technique.
Yeah.
He was born here in Utah, trained at the University of Utah, and was a neurosurgeon in Honolulu, Hawaii for decades. He was the only neurosurgeon in Hawaii when Pearl Harbor was attacked,
Wow.
and did something like 25 craniotomies in 24 hours the first day.
Oh my goodness,
But,
I didn't know that.
Utah
Yeah.
boy pioneered the anterior approach.
That's great. I didn't know that. Yeah.
Just a question.
You
Yeah.
may get to, but so if this patient had a fracture, unstable fracture, would you then consider a posterior approach?
That's a very good question. I don't think he has an unstable fracture. If he did, we would think about doing an anterior approach still, or doing both. And in some cases with fractures, the appropriate thing is to do both anterior and posterior. The other thing that's probably obvious to many of you is we probably are going to do a fusion here because of the injury to the disc, the spinal cord compression, not a candidate for like a disc replacement. So we did a 2-level fusion, and if you look carefully intraoperatively, we see that little linear fracture through the disc space. But this approach does not involve a lot of blood loss. We really only have to cut the platysma, which we can sew back together, which is that muscle right on the surface, under the surface of the skin. We go just medial to the carotid artery and put the retractors in, pulling the esophagus over, and then we have complete access to the disc space. So we can take the entire disc out, we can take all the bone spurs out, and we can thoroughly decompress the spinal cord and the nerve roots pretty easily. In my hands, a surgery like this would be maybe an hour. So they're not long. And the thing that you cannot do from this approach, unless you take the vertebral body out, is decompress stuff behind the vertebral body. And then the ligamentum flavum is, of course, on the back side of the spinal cord. So if somebody has a really thick ligamentum flavum as a part of their spinal canal stenosis, we may need to do both approaches or come in through the back, because that structure is not accessible from the front. When we do an anterior fusion, we put in cages, which are encouraging bone to grow through them. They hold the disc space open, and the hope is that they will stay there and not subside into the bone. And that's what we did. Yeah.
If you end up doing a posterior approach as well,
Mhm.
do you do it all in one sitting?
Usually, yeah.
How much longer does it take to do the posterior approach on top?
It takes about twice as long. Yeah. There's some positioning time that takes it's harder to position the patient for a posterior cervical, and then you have to dissect down to the spine, which takes some time. The rest of it's pretty quick, but it's really the positioning and the exposure and closure that take quite a bit extra time. So that's a view there before we put the plate and the screws on. And with central cord, they can improve pretty quickly and maybe get back to normal function. Okay, so this is a 41-year-old who presents with mostly radicular pain, C7 distribution, and it's radiating down the arm with associated weakness, has failed, or not, fail's the wrong word. They always say that for the insurance companies, I think, but they've worked with physical therapy and maybe had an injection and worked with the chiropractor, but now we're thinking about surgery. So first, what do you see? This is a little grainy, I apologize for that, but what do you see on the image here? Without any arrows. So
Posterior protrusion of the C6-7 disc.
yeah, disc herniation here. Anything peculiar about the disc herniation?
Press on the spinal cord.
Yeah, I don't have an axial here, but it's pressing on the side of the cord and then into the nerve as it exits. The rest of the cervical spine looks pretty healthy. I don't have this shown on the imaging, but the facet joints look pretty healthy. So if you're thinking about surgery for something like this, what would you be considering? And why would you want to do a disc replacement? Besides, it just sounds like the right answer.
Sounds good.
Just to keep the motion.
Okay, good. Anybody else have a different opinion or option? You can do a discectomy in the cervical spine, and I have found those to have a higher complication rate. They're harder to do, and with disc replacement, they're not. The disc replacement's more definitive, and so we rarely do just a discectomy in the cervical spine.
Why is the discectomy harder than just putting in, because you're taking out disc
Yeah.
when you're doing
Yeah.
aortic replacement?
So when you do a discectomy in the lumbar spine, you're working around a sac of nerve roots that you can move around. You also don't have as much access from the front. It's a lot harder to get to the lumbar spine from the front. It's pretty easy to get there from the back. In the cervical spine, what's between you and the disc when you come in through the back? Spinal cord, not nerve roots, not cauda equina. And so you cannot retract the spinal cord. And so you're working in a small window between the nerve and the spinal cord, trying to get the herniation out. And it's a much higher risk situation because you cannot retract the spinal cord. So it's a very good question. And people do it endoscopically now, so there's definitely some direction towards doing more discectomies in the cervical. But by and large, I think most people anymore are going to do an ACDF or disc replacement from the front. Yeah.
With doing discectomy, because you're taking out the disc, disc replacement,
Mm-hmm.
you're essentially taking out the disc, does that just give you more access to be able to do that? Because you're going to take out all that private cortex.
Yeah, so when you do a discectomy or an ACDF, the first step is to do the full decompression. Remove the entire disc, any bone spurs, the herniation, so that you get this view of the dura over the spinal cord and the nerve roots going out. And you look at it and you say, okay, everything's decompressed. The next step is to do the reconstruction, which I agree that this would be a good candidate for a disc replacement. It also, patient would do very well with a fusion as well. When there's lots of studies now that show disc replacement is safe and effective. Across all of the studies, the patients required fewer reoperations, less adjacent segment disease, preservation of motion when compared to fusion. And the data now is out more than 20 years, so it's not a short-term thing anymore.
So is the data still like for lumbar discectomy, like 8 to 9% chance of reherniation? Is it similar in the cervical spine? Or?
So if you do an ACDF or a disc replacement, you've removed the whole disc.
No,
So,
I'm saying a discectomy.
but if you, I don't know. I bet that it's higher. I just don't do that many cervical discectomies, and I don't think that it's a pretty unusual case to have an isolated herniation right in a spot you can get to. But I don't know the answer exactly, but I would suspect it's a little bit higher. It's a good question, though. So when we do, this also shows the exposure. Again, there's very little bleeding. We put those pins above and below the disc. Not every surgeon does that. I don't know why they don't do that, but it's the way to do it. We put the disc a little bit on distraction, which makes it easier to remove. It also opens up the space to work. And then we cut the annulus, which Mickey knows what that is now. And we remove the disc completely. And then get to the back of the disc, file down the bone spurs, remove the herniation, the posterior longitudinal ligament, and then again put the artificial disc in. Does anybody know what structure is being drilled right there? Paul knows. Yeah, so what my initial chairman in residency used to say, show me the smile. And what he meant by that is take the disc out completely enough and get lateral enough to see the curve of the uncovertebral joints on the two ends of the disc space. And what passes under the uncovertebral joint? It's the nerve root. So if you can get out to the joint, file it down, and get underneath it, that's where the nerve root's going to be. So I like to get pretty wide with the decompressions. And I think maybe that's part of the herniation that came out there. So again, this is the view, and we would get this view on an ACDF as well. And then we put the artificial disc in, and pretty straightforward.
What material is used for the disc?
That's a good question. So there's a metal alloy, which I think is cobalt, chromium, molybdenum, and titanium. And then like a medical grade plastic inner core, very similar to like a hip replacement, at least in terms of the biomaterials that are used. And the way I do it is I mark where the nerve exits and then where I think the midline is, and I put it right between the two nerves because I can just visualize where the nerves are. And that's been a pretty good way for me to do it. And the implant just taps in under X-ray. It's not that complicated. That's really it. So, okay, disc replacement. All right, so look at this case now. This is a 61-year-old with worsening upper extremity strength, has been dropping things, discoordination with hands, difficulty with fine motor movements. What do you see on this MRI? Yes, the spinal cord is compressed across at least 2, maybe 3 segments. Very good. Yeah?
Concerning because it's upper cervical.
It's higher in the cervical spine. Yeah. Would that influence your approach to something like this?
I personally wouldn't be able to operate on this.
Yeah. Me neither.
Well, what I've learned from rounds is that's a tricky procedure at best.
You're learning a lot. Yeah, it's great. I will say that when you get up into the beyond up higher than C3-4, you're really risking swallowing. It's hard to get to C2-3 from the front. You can, but it's not easy. Anything else that you see on this that's unusual?
A lot of arthritis in the vertebrae?
There's a lot of arthritis. It looks way more arthritic than either of the two cases that we saw. Would you do any additional testing? Do they have osteoporosis? That's always a good idea, looking into surgery. Anything else?
Would you use neural monitoring in a procedure like this?
Yes, probably you would. Yep. It's a good question.
Do they have a positive Hoffman sign?
Uh-huh. Yeah, so definitely have cervical myelopathy. Definitely a surgical candidate.
Do you want to know what their motion is? Like, do dynamic x-rays?
You could do dynamic x-rays. We did not do that, but I would presume there wasn't very much motion.
CT scan?
Tyler, from outside the room, says to do a CT scan. And so that's a good idea. What do you see now on the CT that's different, or more obvious, I should say, than you see on the MRI? What's that?
On the disc narrowing on there.
Is it
Like the
calcified?
space calcification.
Yeah, the discs are definitely narrow, and then you have this big calcified and ossified posterior longitudinal ligament. So this is a case called ossification of the posterior longitudinal ligament. The ossification extends from bottom of C2, 3, 4 down to the C4, 5 disc. Okay, so if you're going to do surgery for this, what approach would you consider doing?
Would you have to go posterior to get to all that ossification?
So you could go in anteriorly and remove both of these vertebral bodies and then be looking at the spinal cord because the dura is fused to the ossified bone. But you can go anteriorly. It's not the wrong answer, but it is a very hard surgery. So I chose on this to do a posterior decompression, and I'll show you that. So we've done our exposure. I decided to put screws in. That's not necessarily right or wrong. The patient did have a little kyphosis, so we want to maintain his alignment. This is real time, obviously. And all I really did here is do a laminectomy and remove the bone above and below where the stenosis was. But I don't want to put anything into the canal where the narrowing is. So once I did that, I drilled out to the side and lifted it all off in one piece. And so this is where we are making, well, we drilled and then made the cuts on either side of this big block of bone overlying the spinal cord where it was pinched. Advantages to a posterior approach is up higher in the cervical spine. We won't have the swallowing issues that we would with an anterior approach. We can decompress the spinal canal more thoroughly with a posterior approach because we can just unroof the whole thing, and that's very powerful. And then if there's pathologies like ossification of the posterior longitudinal ligament, we can sort of just bypass the hard part of the surgery and not even do anything about it, which is really nice. So this is where I don't remember who did this surgery with me, but I asked them to carefully lift up, or maybe I was the one lifting. Anyway, we just lift up, and you don't want to lift and then have it plunge down. So you lift up and then you just free up the soft tissue, and there's the spinal cord or the dura over the spinal cord completely free. Okay, final case. We just have a couple of minutes, but this patient presented with I think he just had a fall. Like, it wasn't the most high energy impact, and he came in with weakness in his arm and radicular pain, but he was only a little bit weak. It wasn't like he was paralyzed from this. But what do you see on the MRI and CT?
Would that be retrolisthesis or C6?
Yeah, there's a listhesis for sure. Let's see, 2, 3, 4. At 5, 6, the 5 is slipped forward. 6 is relative to 5 slipped backward. And you can see it demonstrated again on the CT. And then this is hard to appreciate unless you're scrolling through images because it's just a static image. But lateral mass, they're shingled on top of each other, and all of a sudden this one is jumped over. And it's also fractured, but that's maybe like a jumped facet. It's dislocated, fractured but also dislocated. And it's only that way on one side, not the other side. If they're bilaterally dislocated, usually patients have a spinal cord injury. How would you approach this one?
Posterior approach.
So I think it's easier to do this posterior first and then anterior. The reason to do both is to limit your fusion to one level. And I've seen people struggle trying to reduce it only going in through the front. Or they're planning to do a front and a back, but they go in the front first and they cannot, you don't have the ability to reduce the fracture. You come in through the back, we can just remove the corner there, put screws in, pull it back into alignment, make sure any fragments are out of the foramen, and lock it down, and then go into the front and do an anterior cervical fusion. And this is halfway through the surgery where we've done the back. The alignment is normal, and then we come in through the front and do our anterior. So anytime that there's a fracture dislocation in the cervical, I tend to go in both sides and usually do the back first. So the way that I sort of think about doing approaches to the cervical spine is recognizing that anterior is less morbid, less bleeding, and less postoperative pain. The main complications with anterior is swallowing and then the occasional vocal cord issue. If we can do a surgery anteriorly, we do it anteriorly. And in some cases, the patients need a combined approach. If we can do an arthroplasty, we do an arthroplasty. Otherwise, we would do a fusion. If a patient has a fracture, osteoporosis, bad arthritic change in the facet joints, or some other contraindication to an arthroplasty. Thank you.